The first question is, identify the name of lymph node shown in the picture. Answer is station 3 prevascular, station 5 subaortic, and station 6 para-aortic. So here we see station 1 is low cervical supraclavicular sternal notch. Station 2 is upper paratracheal. Station 3 is prevascular retrotracheal. Station 4 lower paratracheal. Station 5, that is subaortic. Station 5 is subaortic. Station 6 is para-aortic. Station 7 subcarinal. Station 8, this comes in lower zone, this is paraesophageal. Station 9 pulmonary ligament. Station 10 hilar. Station 11 intralobar. Station 12 lobar, this comes in peripheral zone. Station 13 segmental, and station 14 subsegmental. These are the lymph node station. Then all of the following variables are included to calculate risk for operative mortality based on thoraco score, except ASA score, type of surgery, malignant tumor, and sex. The answer is type of surgery. The thoracoscope is the widely used model to assess the risk of operative mortality in thoracic patient. Risk is calculated based on 9 variables: age, sex, American Society of Anesthesiologists, ASA score, performance status, dyspnea score, priority of surgery, extent of surgery, malignant diagnosis, and composite morbidity score. It is currently the most robust model available to estimate the risk of death when considering patient for thoracic surgery. So the risk is calculated based on 9 variables: age, sex, American ASA score, performance status, dyspnea score, priority of surgery, extent of surgery, malignant diagnosis, and composite morbidity score. So next question is, Mr. X, 50-year-old male old patient with height of 160 cm, have complained of breathing difficulties. He has undergone spirometry tests as per physician advice. Some of the spirometry values are as below. Identify the pattern of lung disease. This FEV1 is 4 liter, FVC is 4.5, PEFR is 380 liter per minute. The answer, the options are obstructive, restrictive, both obstructive and restrictive, and the answer is it is normal. The answer is restrictive. According to the value given, FEV1 and FVC both are decreased, and PEFR is also slightly low compared to normal reference value. So FEV1, here we can see FEV1 divided by FVC ratio is 4 liter. I mean FEV1, that is 4 liter divided by FVC, that is 4.5. Answer is 88%. So it is, since the answer is FEV1 by FVC is more than 80%, this is of restrictive pattern. So the next question is, all of the following are indicators for surgical intervention for pneumothorax except. So the answer is the options are: second ipsilateral pneumothorax, first contralateral pneumothorax, then unilateral spontaneous pneumothorax. Pneumothorax failed to settle despite intercostal drainage. So the indications for surgical intervention for pneumothorax include second ipsilateral pneumothorax, first contralateral pneumothorax, bilateral spontaneous pneumothorax, pneumothorax failed to settle despite chest drainage, spontaneous pneumothorax, and pregnancy. So the indication for surgical intervention pneumothorax is like second ipsilateral pneumothorax. After first pneumothorax, secondly same side, the pneumothorax is on same side, and then second contralateral pneumothorax, like first contralateral pneumothorax, there is another pneumothorax on the opposite side, then bilateral spontaneous pneumothorax. So the indication for surgical intervention for pneumothorax include second ipsilateral pneumothorax. That means after first pneumothorax, the second ipsilateral pneumothorax, then first contralateral pneumothorax, opposite side pneumothorax, then bilaterally spontaneous pneumothorax, the pneumothorax fails to settle despite chest drainage, then spontaneous pneumothorax, and pregnancy. These are the surgical intervention for pneumothorax. Then Safe triangle for insertion for ICD drainage is formed by all of the following except anterior. So the safest site for insertion of a drain is in the triangle that lies anterior to mid-axillary line, above the level of nipple, below and lateral to the pectoralis major muscle. So here options are anterior to the mid-axillary line, then at or above the level of nipple, and below and lateral to the pectoralis major muscle. So the option is anterior to posterior axillary line. Next, all of the following principles should follow while inserting ICD drainage. ICD should be inserted in safe triangle and track should be oblique. ICD should be inserted as it passes over inferior edge of the rib. Drain for pleural effusion should aim towards base, and vertical mattress suture should be omitted if the drain is for empyema. So the option A, the safest site for insertion of a drain is in the triangle that lies anterior to the mid-axillary line, above the level of the nipple, below and lateral to the pectoralis major muscle. Oblique track should be preferred as a skin incision and pleura do not overlie each other and decreases chances of entering air. Option B, ICD should pass posterior to rib to avoid damage to neurovascular bundle that passes inferior to the rib. So this option is wrong. So the ICD should go pass inferior to the rib, not like ICD should. ICD should not pass over inferior edge of the rib because neurovascular bundle are there. So the ICD should pass superior to the rib to avoid damage to the neurovascular bundle. A drain for pneumothorax and pneumothorax should aim towards the apex of the lung. A drain for pleural effusion or empyema should near the base. So if it is hemothorax or pneumothorax, the apex should be towards the drain should be towards the apex, or if for pleural effusion or empyema should be near the base. A vertical metal suture is inserted for lateral wound closure. This is vital for pneumothorax management but should be omitted if the drain is for empyema, provided there is adherence of the pleura, because that tract should lie open. Next question is most common medicinal tumor in adult. The most common medicinal tumor in adult is thymoma. For adult it is thymoma and thymic cyst. For children it is neurogenic tumor. 35-year-old male patient has complaints of dyspnea. His face found congested with dilated vein found over neck. He was undergo CT chest. 5 into 3 cm size minimal enhancing tumor found in the anterior mediastinum. FNA biopsy was taken, found to be have normal level of FAP and slightly altered HCG level. What will be the treatment for this? So the treatment is chemotherapy. This case history represents superior vena cava compression due to germ cell tumor in the anterior mediastinum. Tumor markers are near normal suggestive of semi-normal. Chemotherapy include bleomycin and etoposide or vinblastine is the best option for this advanced disease. Surgical excision is good for small asymptomatic seminomatous tumor. 40-year-old male patient found to have incidental finding of multilocular cystic lesion 5 into 4 cm size in anterior mediastinum on CT scan. What will be the probable cause for this? So it is benign teratoma, multilocular cyst in cystic lesion 5 into 4 cm in anterior mediastinum on CT scan. So benign teratoma is our most common germ cell mediastinal tumor. It presents as multilocular cystic lesion on CT scan. Thymoma is most commonly seen between 40 to 60 years of age. On CT scan, it is present as solitary encapsulated mass. So the next question is 45-year-old male patient with thymoma found to have a microscopic invasions of pericardium. What would be the stage according to Masoka staging? So episode system for thymoma. Stage 1, encapsulated tumor with no gross or microscopic evidence of capsular invasion. Stage 2, gross capsular invasion or invasion into the mediastinal fat, pleural or microscopic capsular invasion. Stage 3, gross invasion into the pericardium, great vessel or lung. Stage 4, a pleural or pericardial dissemination. Stage 4B, lymphogenous or hematogenous metastasis. So stage 1 is encapsulated tumor with no gross or microscopic evidence of capsular invasion. So stage 2 is capsular invasion, which is gross and or invasion into the medicinal fat pleura or microscopic fat capsular invasion. Stage 3 is cross invasion into the pericardium, great vessel or lungs. Stage 4A is pleural or pericardial dissemination. Stage 4B is lymphogenous or hematogenous metastasis. So our next question is, which procedure is performed for and following procedure is performed for which pathology? So this is a NAS procedure used for pectus excavatum. Here the metal bar is placed behind the sternum to brace the sternum in forward position. So it is NAS procedure for pectus excavatum. So lipidic growth pattern seen in which type of lung cancer? Small cell lung cancer, squamous cell lung cancer, bronchoalveolar cancer, large cell undifferentiated tumor. So in bronchoalveolar cancer, which is also adenocarcinoma in situ, tumors spread along the surface of the structure without destructing them. So it is called lipidic pattern. So lipidic pattern of growth is seen in bronchoalveolar cancer because it doesn't invade and it's just spread along the surface of the structure without destructing them. So bronchoalveolar cancer. Then all of the following statements are correct regarding neuroendocrine tumor, except neuroendocrine tumor occurs most commonly in peripheral location. So the options are small cell lung cancer is one of its type regarding neuroendocrine tumor. Then neuroendocrine tumor occurs most commonly in peripheral location. Then surgical excision is preferred treatment. Most neuroendocrine tumor behave as benign tumor, but 15% metastasize. So the options are: option A, neuroendocrine tumor of the lung are a group of lung cancer that includes small cell cancer and large cell undifferentiated lung cancer, but also include other less aggressive tumor types, including typical carcinoid and atypical carcinoid tumor. So option A was small cell lung cancer is one of its type. So it is correct that neuroendocrine tumor of the lung are a group of lung cancer that include small cell cancer and large cell undifferentiated lung cancer, but also include other less aggressive tumor, including carcinoid, atypical carcinoid and atypical carcinoid. And option B is neuroendocrine tumor occurs in major central bronchi and 20% are found in periphery. So the option is wrong. Here it is said that neuroendocrine tumors occurs most commonly in peripheral location, but it is mostly seen in the central location. So option C is surgical excision is preferred because the prognosis following complete resection is excellent. That is more than 90%, 10-year survival. Segmental or biopsy resection may be sufficient for small peripheral tumor, while lobectomy or pneumonectomy may be necessary for central tumor. So it is correct that surgical excision is preferred treatment. Then fourth one is most neuroendocrine tumor behave as benign tumor and but 15% metastasize. So it is written most behave in benign way, however approximately 15% metastasize. So now MCQ 14, lung adenocarcinoma size 5 cm involving phrenic nerve is classified as which stage? So we have to learn the staging of So TX is T is primary tumor. TX primary tumor cannot be assessed or tumor proven by presence of malignant cell in sputum or bronchial washings, but not visualized by imaging or bronchoscopy. So that is TX. Then T0 is no evidence of primary tumor. TIS is tumor carcinoma in situ. Then T1 is tumor less than 3 cm in greatest dimension surrounded by lung or visceral pleura less than 3 cm in greatest dimension surrounded by lung or visceral pleura without bronchoscopic evidence of invasion, more proximal than the lower bronchus, that is not in the main bronchus. So T1A is minimally invasive adenocarcinoma. T1A MI. Then T1 is tumor 1 cm in greatest dimension. T1B is more than 1 cm but less than 2 cm in greatest dimension. T1C is more than 2 cm but less than 3 cm in greatest dimension. T1C is tumor more than 2 cm but less than 3 3 cm in greatest dimension. Then T3, tumor more than 3 cm but less than 5 cm, or tumor with any of the following features, like involving main bronchus regardless of the distance from the carina but without involvement of the carina. Second is invades visceral pleura. Third is associated with atelectasis or obstructive pneumonitis that extend to the hilar region, involving part or all of the lung. Then 2A is tumor more than 3 cm but less than 4 cm in greatest dimension. Then 2B is tumor more than 4 cm but less than 5 cm in greatest dimension. T3, tumor more than 5 cm but less than 7 cm in greatest dimension or associated with separate tumor nodules in the same lobe as the primary tumor, or directly invades any of the following structure: chest wall, including the pleural, parietal pleura, superior sulcus tumor, phrenic nerve, or parietal pericardium. So here and T4 is tumor more than 7 cm in greatest dimension or associated with separate tumor nodules in a different ipsilateral lobe than those of the primary tumor, or invades any of the following structure: diaphragm, mediastinum, heart, blood vessel, trachea, recurrent laryngeal nerve, esophagus of vertebral body, and carina. So the question was lung carcinoma, size 5 cm, involving phrenic nerve, is which stage? So the answer is stage 3. Here phrenic nerve is involved. Then chest wall, pleura, including the parietal pleura, superior sulcus tumor, and the parietal pericardium. Then stage 4 is more than 7 cm in greatest dimension, invades diaphragm. If it invades diaphragm, then it is 4. Diaphragm, mediastinum, heart, great vessels, trachea, recurrent laryngeal nerve, esophagus, vertebral body, and carina. That is stage 4. So next question. Identify the correct match regarding paraneoplastic syndrome and tumor which produce it. So the options are: A is hypercalcemia, B is hypertrophic pulmonary osteoarthropathy, then C is hyponatremia, and D is gynecomastia. Then tumor causing it are small cell lung cancer, squamous cell lung cancer, large cell lung cancer, and adenocarcinoma. So the answer is A2, that is hypercalcemia, is seen in squamous cell lung cancer. Then B4, that is hypertrophic pulmonary osteoarthropathy, is seen in adenocarcinoma. C1 is hyponatremia and small cell lung cancer, and D is gynecomastia and is seen in large cell lung cancer. So here we can see the answer. Paraneoplastic syndrome produced by lung cancer as follows: small cell lung cancer, here we see hyponatremia, Cushing syndrome, Eaton-Lambert syndrome, retinal blindness, cerebellar degeneration, and SVC obstruction syndrome. Then 2 is squamous cell lung cancer. Here we see hypercalcemia, then hypophosphatemia and clubbing. Then in adenocarcinoma we see hypertrophic pulmonary osteoarthropathy, then DIC, then migratory thrombophlebitis. And last one is large cell cancer. Here we see gynecomastia or galactorrhea. So the next question is lung cancer most commonly metastasized to which site? So it is most commonly metastasized to CNS. Next is mediastinoscopy. Mediastinoscopy allows examination of which station lymph node among following. So it allows examination of station. A 45-year-old man, patients were complaining of dyspnea undergo CT scan in which 4.5 cm size tumor found in peripheral location. Patient undergo VATS guided biopsy. On VATS, visceral pleura found to be involved. Biopsy is suggestive of poorly differentiated non-small cell lung cancer. No lymph node found to be involved. What would be the next best step for him? So this case suggests the patient is in T2B N0 tumor with high risk features. NCCN guidelines recommend chemotherapy for it. So National Comprehensive Cancer Network guidelines currently recommend observation for T1A, T1B, and T1C, and node negative, completely resected NSCLCs, that is T1, ABC, N0, M0. For patients with larger tumor T2A or T2B that are node negative, it is recommended that chemotherapy be considered in high-risk patient. Ideally, in the setting of clinical trial, high-risk tumor characteristics including polydifferentiated tumor, moderately to polydifferentiated lung, neuroendocrine tumor, vascular invasion, resection limited to wedge resection only. So tumor more than 4 cm in size, visceral pleural involvement, and when lymph node sampling at the time of resection was incomplete. So now, 40-year-old male, a patient with diagnosed case of small cell lung cancer has stage of T2B, N1, M0. What would be the best treatment options for him? So for higher than T1 small cell lung cancer, chemotherapy is the ideal option with additions of radiotherapy in advanced case. So previously only we studied all T1 without N0 are recommended for observation. Then from T2 chemotherapy is given. The grade 4 NEC in rare circumstances where small cell lung cancer represents as an isolated lung lesion, lobectomy followed by chemotherapy is warranted after surgical medicinal staging has confirmed the absence of N2 disease. Grade 4 NEC lung cancer in rare circumstances where small cell lung cancer presents as an isolated lung lesion, lobectomy followed by chemotherapy is warranted after surgical medicinal staging has confirmed the absence of N2 disease. Often ultrasound guided FNA provides a definitive positive diagnosis and more invasive approaches are not needed. However, less than 5% are stage 1 and there is no benefit from surgical resection for more advanced stage disease. Treatment is chemotherapy with or without radiation therapy depending on the extent of the disease and the patient performance status. Now, all of the following are indication for surgical drainage of lung abscess except indication for surgical drainage procedure for lung abscess include failure of medical therapy, abscess under tension, abscess increasing in size during appropriate treatment, contralateral lung contamination, abscess more than 4 to 6 cm in diameter, necrotizing infection with multiple abscess, hemoptysis, abscess ruptures or pneumothorax, inability to exclude a cavitating carcinoma. So failure of the medical therapy, abscess under tension, abscess increasing in size during appropriate treatment, contralateral lung contamination, abscess more than 4 to 6 cm in diameter. Then necrotizing infections with multiple abscess, hemoptysis, abscess rupture or pneumothorax, inability to exclude a cavitating carcinoma. Next question is, Penco's syndrome occurs due to which lung cancer most commonly? Small cell lung cancer, Penco's syndrome occurs originating in the superior sulcus. It is posterior apex, apical chest wall and or shoulder pain from the involvement of the first rib and chest wall. Horner syndrome, unilateral encephalomos, proptosis, meiosis, and facial endohydrosis from invasion of the sympathetic ganglion and radicular arm pain. So, Penco's syndrome occurs due to most commonly squamous cell lung cancer. All of the following are indications for invasive medicinal staging in lung cancer except indication for invasive medicinal staging in lung cancer: radiographically enlarged medicinal lymph nodes, centrally located lymph nodes, then N1 nodal enlargement, tumor size more than 3 cm, peripheral clinical staging stage 1 tumor with non-enlarged but FDG with medicinal lymph nodes. All of these are indication for invasive medicinal staging except. So here radiographically enlarged medicinal lymph nodes. This is the first option. Then tumor size more than 3 cm. Radiographically enlarged medicinal, when there is radiographically enlarged medicinal lymph nodes, we do medicinal staging. Then centrally located tumor and then N1 nodal enlargement, then tumor size more than 3 cm. Peripheral clinical staging 1. Peripheral clinical stage 1 tumor with non-enlarged but FDG medicinal lymph nodes. So here the correct answer is peripherally located tumor. So next question is, all of the following are contraindications for radiofrequency ablation of lung cancer except the contraindication for radiofrequency ablation. We cannot do RFA, tumor size more than 5 cm. Second is tumor abutting hilum, and associated malignant pleura or pleural effusion. The more than 3 cm, 3 lesion in one lung, then presence of pulmonary hypertension and proximity to lung vessels, large vessels. So these are the tumor. The first option is 6 cm, so we cannot do RFA for tumor more than 5 cm. Then second one is 3 cm size tumor abutting hilum. So any tumor which abutes the hilum, we cannot do radiofrequency ablation there. Then the fourth is presence of pulmonary hypertension. So presence of pulmonary hypertension or pleural effusion, proximity to any large vessel, or more than 3 lesions in one lung. So there we cannot do radiofrequency ablation. Next is 50 years old male patients have complaints of swelling over right anterior aspects of the chest for 1 year, which slowly increases in size to present 4 into 3 cm. He also has complaints of pain over swelling side. The following CT shows the lesion. What will be the treatment? So this picture showing right anterior chest wall tumor involving ribs, which shows stippled calcification. That is pathognomic of chondrosarcoma. Chondrosarcoma is resistant to chemotherapy and radiotherapy. Any tumor involving the chest wall with ribs with stippled calcification. So the chemotherapy or radiotherapy doesn't work. So we have to do surgical excision. So next is 20-year-old female patient undergone chest CT screening to rule out COVID-19. Incidentally, following lesion found, what will be the next best step for it? So it is this picture showing island of thymic tissue, fat density lesion surrounded by soft tissue density. This suggests thymolipoma. Surgical excision is recommended for this large size tumor. So it contains some thymic tissue. And then fat density lesions surrounded by soft tissue. So thymolipomas are rare benign tumor that may grow to a very large size tumor to diagnosis. On CT scan, their appearance can be dramatic with a characteristic fat density spotted by islands of soft tissue density representing islands of thymic tissue. Thymolipomas are generally well encapsulated soft pliable mass that do not invade surrounding structure. Dissection is recommended for large muscles. So 35-year-old male patient has undergone CT scan for recurrent chest pain, found to have 2 cm nodule in right lower lung. There is high probability of cancer assessed on CT scan. What would be the next best step for him? So this patient undergo thoracoscopic surgery and this patient should undergo a video-assisted thoracoscopic surgery and biopsy of frozen section. If found to be malignant, should undergo resection. So the question is, 35-year-old male patient has undergone CT scan for recurrent chest pain and found to have 2 cm nodule on right lower lung. The recurrent chest pain here we see that when there is low probability of cancer, serial high resolution CT at 3, 6, 12 and 24 months we do. When there is immediate possibility of cancer, we do PET imaging or CT dependent institutional expertization, and then thoracoscopic fine needle aspiration, then bronchoscopy if air bronchogram presence or if any cofactor has expertise with, and then if there is high probability of cancer, we do video assisted thoracoscopic surgery, examination of a frozen section followed by resection if nodule is malignant. So here we see that the 35-year-old man has undergone CT scan for recurrent chest pain and then found to have 2 cm nodule on right lower lung. There is high probability of this cancer assessed on CT scan. Since there is high probability, so we will do PETs. Then all of the following are indication for surgery. Question number 27 is, all of the following are indication for surgery in myocardial pulmonary infection except hemoptysis, bronchiectasis, pleural tuberculosis, non-tuberculous myocardial infection. So what are the indication for surgery to treat myocardial pulmonary infection? These are complications resulting from previous thoracic surgery to treat tuberculosis, failure of optimized medical therapy like progressive disease, lung gangrene, or intracavitary aspergillosis superinfection. The need for tissue acquisition for definitive diagnosis. Then fourth number is complication of pulmonary scarring like massive hemoptysis, cavernomas, bronchiectasis, or bronchiostenosis. Then extrapulmonary thoracic involvement. Then pleural tuberculosis and non-tuberculous myocardial infection. So in option we saw there are bronchiectasis. So bronchiectasis is an option for indication for operation, like surgical intervention. Then second is pleural tuberculosis. Pleural tuberculosis also an option. Then third number is non-tuberculous myocardial infection. These are also an option for indication for surgery. Then here it is written hemoptysis, but the indication is massive hemoptysis. So the option is hemoptysis. Now all of the following lead to transudative pleural effusion except. So Meigs syndrome leads to exudative pleural effusion. It involves riot of ovarian tumor, pleural effusion, and ascites. So all of the following leads to transudative pleural effusion except. So which will leads to exudative pleural effusion. So hypoalbuminemia, myxedema, sarcoidosis, this will lead to transudative but not exudative. But Meigs syndrome leads to exudative pleural effusion. It involves riot of ovarian tumor, pleural effusion, exudative pleural effusion, and ascites. So transudative pleural effusion includes congestive cardiac failure, then cirrhosis, nephrotic syndrome, superior vena cava obstruction, Fontaine syndrome, then urinothorax, and peritoneal dialysis. Then glomerulonephritis, myxedema, hypoalbuminemia, sarcoidosis, cerebrospinal fluid leaks to pleura, then pleural pulmonary emboli. Question number 29. 45-year-old male patients with pleural effusion undergo biopsy due to no response to conservative management and thoracocentesis found to be normal. Immunochemistry and electron microscopic features are as follows. Which should be cause for it? CEA negative, vimentin positive, low molecular weight, cytokeratin positive, electron microscopy, long sinus villi. So 45-year-old male patient with pleural effusion undergo biopsy due to no response to conservative management and thoracocentesis found out to be normal. So this is a case of malignant pleural effusion. These IHC and electron microscopic features suggest mesothelioma. So differentiation of mesothelioma from adenocarcinoma, immunohistochemical results, carcinoembryonic antigen, mesothelioma is negative and adenocarcinoma is positive. In adenocarcinoma, this CEA is positive, but in mesothelioma it is negative. Then vimentin is positive in mesothelioma. Then adenocarcinoma, vimentin is negative. Then low molecular weight cytokeratin is positive in mesothelioma, but in adenocarcinoma it is negative. Electron microscopy features include long sinus villi, but in adenocarcinoma it is short villi with fuzzy glycocalyx. So the answer is mesothelioma. Now identify the correct maths regarding scientists and their discoveries. So the correct answer is C, that is A. Debicki is correct. Is the first successful. He did the first successful CABG. Then Gibbon did the cardiopulmonary bypass machine. So Gibbon discovered the first cardiopulmonary machine, and then Debicki did the first CABG. Then Buchberg, the first use of blood cardioplasia as a preferred method for arrested myocardial protection. Then Subramaniam, he did the first beating heart CABG. Now all of the following statements are correct regarding coronary artery anatomy except. So first option is left anterior descending artery is the most frequently diseased coronary artery and most often bypassed during CABG. Common site of stenosis of the right coronary artery are in its proximal portion or at its bifurcation or crux. C is anatomical dominance is determined by artery that supplies anterior descending artery. And fourth is coronary artery arises from ostia in the aortic sinus above aortic valve, right from the anterior sinus and left from the posterior sinus. So the questions of anatomical dominance is determined by artery that supplies the posterior descending artery, not the anterior descending artery. In approximately 90% of the cases, the posterior descending artery arises from right coronary artery. A pattern are referred to as a right dominance. The posterior descending artery can also rise from the circumflex artery, a pattern referred to as a left dominant, which occurs in approximately 10% of cases. So, all are correct except the anatomical dominance is determined by artery that supplies the posterior descending artery, not the anterior descending artery. So others are correct. These are left anterior descending artery is the most frequent. Left anterior descending artery is the most frequently diseased coronary artery and most often bypassed during CVG. Then common sites of stenosis for right coronary artery is proximal portion of bifurcation. Then the coronary arteries arise from the ostia in the aortic sinus above the aortic valve, right from the anterior sinus and left from the posterior sinus. So the next question is, all of the following are correct regarding pathophysiology of ischemic heart disease except option is atherosclerosis is chronic inflammatory process that lead to formation of focal obstruction or plaque in large and medium-sized arteries. Fatty streak is first evidence of atherosclerosis and found after 15 years of age as yellow streak. Fibrous plaque is consisting of large numbers of smooth muscle cell, foam cells and leukocytes, and ruptures of fibrous tissue leads to formation of thrombus. So the option is option A. Atherosclerosis is a process underlying the formation of focal obstruction or plaques in large and medium-sized arteries. It is accepted that atherosclerosis is a chronic inflammatory process resulting from interaction between plasma, lipoproteins, leukocytes, monocytes, macrophages, T lymphocytes, vascular endothelial cells, and smooth muscle cells. Option B. The fatty streak. The first evidence of atherosclerosis can be found in children 10 to 14 years of age. This appears as a yellow streak running along the major arteries. The streak consists of smooth muscle cells which are filled with cholesterol and foam cells. So this option is wrong. So here fatty streak is seen. They say first evidence of atherosclerosis found after 15 years of age as yellow streak. But the first evidence of atherosclerosis can be found in children 10 to 14 years of age. This appears as a yellow streak running along the major arteries. The streak consists of smooth muscle cells which are filled with cholesterol and foam cells. So the option is wrong. Then the fibrous plaque. The fibrous plaque consists of large numbers of smooth muscle cells, foam cells, leukocytes. As the fibrous plaque grows, it projects into vessel leading to lumen narrowing that in turn can lead to ischemia or infarction. When the fibrous plaque ruptures, provoking activation of the coagulation cascade, the formation of thrombus occurs. So next question is, isotope that is used to scan myocardial perfusion is the main type of radionucleotide study used in myocardial perfusion scanning using specific radioisotope is 201 Thallium to assess significance of coronary disease and viability of the myocardium. Other isotopes and their uses are as below. So the next question is, all of the following are indication for CABG except. So indication for CABG, triple vessel disease is an indication for surgery. Indication for surgery are more than 50% of the stenosis of the left main stem. This critical main stem disease, more than 50% stenosis. Then more than 50% stenosis of the proximal left anterior interventricular artery. Then 2 or 3 main coronary artery disease. This triple vessel disease and poor ventricular function associated with multivessel disease. So the question is, all of the following are indication for CABG except. So more than 50% of the all of the following are indication for CABG except that is double vessel disease. All of the following are correct regarding complications of myocardial infarction except mitral valve papillary muscle necrosis cause acute mitral regurgitation which require mitral valve replacement. Ventricular septal rupture presents 1 to 3 days after infarction with pulmonary edema. And systolic murmur requires repair with pericardial or Dacron patch. Ventricular aneurysm repair is undertaken using cardiopulmonary bypass. Pulmonary papillary muscle necrosis produces systolic murmur. So the option is B. So the question is, all of the following are correct complications of myocardial infarction except. So all are complication of myocardial infarction except B. So option 1 is myocardial valve papillary muscle necrosis causes acute mitral regurgitation, append-systolic murmur, pulmonary edema. Diagnosis is made by endocardiography and right heart catheterization. Mitral valve replacement is usually necessary, but the mortality rate is higher than in involved replacement for non-ischemic valvular disease. Option D is ventricular septal rupture, typically presents 3 to 7 days after infarction with pulmonary edema. Here it is saying 1 to 3 days, but the ventricular rupture, septal rupture typically presents 3 to 7 days after infarction with pulmonary edema. Append-systolic murmur and hemodynamic instability. The diagnosis is usually confirmed with echocardiography. Repair is with a pericardial or artificial recurrent patch. So this option is wrong. So option C, ventricular aneurysm occurs following partial thickness necrosis of the ventricular valve if the free valve is replaced with non-contractile fibrous tissue. Left ventricular function is affected because the fibrous valve balloons out during systole and increases the acute stroke volume. Repair is undertaken using CPB and CABG undertaken at the same time if necessary, combined with valve replacement if needed. Option D is papillary muscle necrosis produces pansystolic murmur. And all of the following are components of the tetralogy of Fallot except. So 4 components of intracardial lesions describing under tetralogy of Fallot are ventricular septal defect, overriding of aorta, pulmonary stenosis, right ventricular hypertrophy. So it is written left ventricular hypertrophy. The answer is right ventricular hypertrophy. Next question is, all of the following are cyanotic congenital heart disease except. Cyanotic congenital heart disease are all the T's we see, the tetralogy of Fallot, transposition of great vessels, total anomalous pulmonary venous drainage, Eisenmenger syndrome. Then acyanotic congenital heart disease are like patent ductus arteriosus, coarctation of aorta, atrial septal defects, and ventricular septal defect. In cyanotic heart disease, all start with T's except the Eisenmenger syndrome. So here we see the patent ductus arteriosus is the acyanotic heart disease, congenital heart disease. So all of the following are correct except correct regarding mitral stenosis except. So mitral stenosis produce characteristic ejection systolic murmur. This is wrong. So the rheumatic heart disease is most common cause of mitral stenosis. ECG may show P mitral or AF, atrial fibrillation. Then D is mitral valve opening area to in an asymptomatic patient is indication for surgery. The common causes of mitral valve disease are rheumatic heart disease, calcification of valve or chordae, then congenital. So this is option A is correct. Option B is the ECG may show left atrial enlargement, P mitral or atrial fibrillation, right axial deviation, and other ECG signs of right ventricular hypertrophy. Tall QRS complex in the right ventricular leads. Then option C is mid-diastolic murmur is an characteristic murmurs of mitral stenosis. So here it causes option C. It tells कि mitral stenosis produce characteristics of ejection systolic murmur, but mid-diastolic murmur is the characteristic murmur of mitral stenosis. Ejection systolic murmur is the characteristic stenosis of atrial stenosis and pulmonary stenosis. But in mitral stenosis, mid-diastolic murmur we see. So option D, in option D, indication for surgery in mitral stenosis. When we do mitral stenosis surgery, symptomatic patient with mitral valve area less than 1.5 cm square, asymptomatic area with less than 1 cm square. Then pressure with gradient more than 10 mm between atrium and ventricle, and then pulmonary capillary wedge pressure is more than 25 mm mercury. So the indication for surgery is if the patient is symptomatic, then less than 1.5 cm square. If asymptomatic, less than 1 cm square. Then the pressure gradient between atrial and ventricle is more than 10 mm mercury, and then pulmonary capillary wedge pressure is more than 25 mm mercury. 60-year-old patients with no history of diabetes, hypertension, stroke, who have left atrial thrombus due to mitral stenosis, what would be the anticoagulation of choice for him? And congestive failure is not present. So the table is CHAD-S2 score for atrial fibrillation, stroke risk and recommendation. Points are congestive cardiac failure 1, hypertension 1, age more than 75 1, diabetes 1, and then stroke, previous history of stroke 2. So points are additive for each other. Score 0, 1, moderate is 2 to 6, and high risk. Recommended therapy for low risk is aspirin 75 to 325 mg daily. For moderate risk, warfarin or aspirin, and for high risk, warfarin. So if the patient is having congestive heart failure with hypertension, with diabetes mellitus, with age more than 75, and with previous history of stroke, and if the patient is low risk like 1, then the patient should get aspirin. For moderate risk like 2 to 6, then warfarin or aspirin, and for high risk, warfarin warfarin is the drug of choice. So here, since the patient is less than 60 years, less than 70 years, and the patient is, there is no history of diabetes, hypertension, and there is no history of stroke. Okay, there is history of stroke, but there is no history of diabetes. So here we see the patient is having only stroke, and other options are 0. So if the patient is history of stroke, then that is 2, and that comes for intermediate risk. And in intermediate risk, we can, like in moderate risk, we can use either warfarin or aspirin. So here warfarin, there is, so we use aspirin. Then 50-year-old male patient diagnosed to have aortic dissection involving descending thoracic aorta. It is associated with severe pain and oliguria. So what will be the treatment of choice? So this case history suggests complicated type B aortic dissection. So percutaneous endovascular stent is the standard intervention of choice.